we have seen how the VOR responses work. Okay, why did we study about the vestibular ocular reflex? Because in most of the disordered pathological conditions, your VOR is very helpful in understanding where the problem is. Okay, and we have seen about the relationship between the one semicircular canal and the responsible muscles, extraocular muscles. Okay, the movement of if the movement of the eye has to do with the movement detected in your semicircular canal. Okay, so if there is a right left movement, which means right left movement of the eye, which means the horizontal canal has detected some motion. Okay, so this is helpful in the identification of the pathology or pinpointing which semicircular canal has the problem. How? We have heard about the nystagmus. Nystagmus is about the rapid involuntary movement of eye. It could be right left, it could be up down, or it could be rotational also. Okay, depending on which semicircular canal is affected. Okay, now what happens here? We are speaking about a motion induced left beating nystagmus. Okay, we will see detailed of it in the ENG part because we will be measuring the nystagmus. We will speak about how we are measuring the nystagmus intensity, everything. For today, we are speaking about only the anatomy and physiology, so we will not be going deep into it. Okay, so what happens when a person is turning? This is your right side, this is your left side. Okay, and the person is actually turning towards his left side. So, and you can see this part, this is your division, this arrow is your division. Before that, here, this part and this part is your pre-stimulus, which means before the turning of the head, both the semicircular canal were firing at a spontaneous rate. Okay, so you can see that this point and this point and this point both have the same firing rate. Okay, now the person is turning towards the left side. Okay, what happens? Just a minute, I will spotlight. Okay, so what happens here? The after turning, the firing has increased, which is excitation. Okay, and the other side, what happened? The inhibited responses, which means less firing compared to your spontaneous rate. Okay, so this exactly shows about the firing of the nerve. Okay, and this is exactly how the vestibular nuclei gets input. Okay, so before that, the half of it is your pre-stimulus, pre-turning. After the head has turned, you have received so much of inputs in your vestibular nuclei, and you have received less responses in the uh, other side vestibular nuclei. Okay, and this here is your spikes per at the given point of time, like your histogram. Okay, so it was in 100 spikes per second normally. Okay, usually the spike rates will be 70 to 100 when there is no activity, no head movement, just static. I'm sitting. Still, my nerve, vestibular nerve, is firing at 70 to 100 spikes per second. Okay, when there is an activity, it increases. When there is no activity, it decreases. Okay, when mean its inhibition, it decreases. Okay, so what happens because of excitation? From 100 it has moved to 150. Okay, because of excitation. When there was inhibition, from 100 it went to 50, it has come down. Okay, so this is what is happening here. What happens is when there is a movement of left side, the eye will try to move towards the right side, correct, and the opposite side. So in this chart, the up is means the right, down is means the left. Okay, so when I turn towards the left, slowly the eye is moving towards my right side, correct? Okay, and at this point we stopped, and then the saccadic eye movement takes over. The saccadic movement takes over. What it does, it tries to bring the interest, the what is it, I need to concentrate on something. Okay, so the saccadic movement is important for me. When there is an involuntary movement, what happens, the VOR takes place. Okay, when there is a voluntary movement, then saccadic response takes place. So slowly the movement is from the right side. Okay, and then a sudden change to bring the area of the image which is important for me, and I want to look into it. So the sudden the eye is moving towards the left side because my area of interest on the left side. Okay, so what you see here, a sudden change on the left side. You're looking at it. Okay, so in the increase, the slow phase here from this point to this point is a slow phase, which means it is VOR, which is making the slow phase from when the head is turned towards the left side, the eye is moving towards the right side. But then suddenly, due to saccadic movement, the eye is turning from the right side to the left side suddenly. Okay, this is your fast phase. Okay, then then the left side it goes up, then it comes again. Okay, so this is how it is. I have it out. Okay, those who have other classes, please leave. Don't I will handle this separately. I will send a voice message or send the recording part of it. You can leave for the voice class. Okay, so what happens here is slow movement from the left to the right, left to the right, because the eye moves from the left to the right, and due to saccadic there is a fast phase, sudden movement. Okay, so for now remember that the VOR is responsible for the slow phase of the nystagmus, and the saccade is responsible for the fast phase of the nystagmus. So the nystagmus will not happen in the normal when there is no head movement. Okay, when there is a head movement, the normals have nystagmus. Okay, nystagmus recording, it's not actually nystagmus, but when this actually will not be called as a nystagmus also. When there is no movement, my head is stationary, but still my eyes are moving tick 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 like this, then it is called as the nystagmus. Okay, now let's see what happens in the next one. Imagine there is a problem on the right side. My right side is damaged, so I'm having, or let's call the blood supply to the right labyrinth is gone. So I don't have any responses coming from the right side. Okay, so it is called as the unilateral vestibular lesion. Okay, so what happens now? Right side will not be sending any responses, and the left side will be continuously. This is head stable. Okay, the head is not moving now. Previously the head moved, now the head is not moving at all. Okay, so now if you could see here, the spontaneous rate continues before and after. Okay, before the spontaneous rate was there, and since we had lesion, it is gone. So we don't have these responses here. Okay, so then what happens, the vestibular nuclei also is not getting anything. Okay, here you were getting your vestibular inputs just like the spontaneous ones. Okay, so this exactly is working normal, the left one. So you don't have any change, increase or decrease. There is no excitatory, there is no inhibition. Okay, but when the cochlear when the vestibular nuclei compared to this has more firing, right? So the eye, the brain thinks, the vestibular nucleus thinks that the person is moving towards the left side. How? In the previous example we saw, when the person is moving towards the left side, the person will have more firing on the left side compared to the left ones, right? Likewise, compared to the no response, the spontaneous rate is considered as response. So the brain thinks, the vestibular nuclei thinks that the person is turning towards the left side. What it does, it sends signal to the oculomotor nuclei to command the extraocular muscles to start VOR. Okay, now the person will move towards person's eye will move towards the right side. Okay, why? Because the vestibular nuclei understood that the head is moving towards the left side and the eye has to move towards the right side. Okay, but then we are looking directly in front. Okay, then the saccadic movement takes over and tries to bring back the eye to the midline. I'm looking at something, right? I need to see it. So because of VOR, wrong message from the vestibular nuclei, wrong understanding, my eye, because of VOR, is moving towards the right side. Okay, and suddenly what it does, the saccadic movement tries to bring it back to the left. Okay, and this will keep on happening because this is spontaneous rate, right? This is spontaneous, and every time the spontaneous rate is firing, it considered it as towards the left side. So it looks like I'm turning 1, 2, 3, 4, 5 like this. I keep turning on the left side. So the eye will also keep moving like tick, 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 and it will try to bring it back to midline. So this nystagmus continues. And if you look at the person's eye, it will keep like dancing, tick, 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 tick. Okay, fine. Is it clear? Do you understand it? Any doubts? There are only three. No doubts? All three understood? Okay. So then what happens? This cannot happen because this will create no your vertigo, your nystagmus, everything is like dizzy now. The patient is completely gone. So, but this cannot happen. Is the brain actually is programmed to adapt itself, right? If there is a disorder, it has to adapt itself. What it does, it first does clamping. Okay, it is called as clamping. What does usually clamp does? When we do clamping, it will reduce. If there is a water pipe, which is there's a hose, and if I do clamping, the water flow reduces. Likewise, what it does, this is like the central mechanism. Okay, what the clamping does is it reduces. Okay, it reduces the understanding of spontaneous rate. Okay, look, previously we saw spontaneous rate as this many fibers, this many recordings. Okay, but here look at this, the input that that the vestibular nuclei recorded was reduced. That means the difference between the no signal and the signal is reduced. Look here. Okay, so this one no signal, the difference between this and this is too much, which means the head is moving very fast. It means that the movement is too much. That's why the nystagmus was tick 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 tick. And now the difference between the normal and the abnormal ear is reduced, and that's why you can see that the nystagmus is reduced. So the eye will not be traveling so much from the midline, but it will still be moving because there is a difference, right? So because of clamping, your nystagmus reduced. Okay, then what happens? Then the brain, it already has connection with the cerebellum. Okay, we will not be going deep into it because it is really complex. We need to study about the cerebellum, everything. So there is a part in the cerebellum which sends efferent pathways to the has control over the vestibular nuclei. Okay, so that sends now signal to the vestibular nuclei saying that there is some signal. Okay, the nerve actually is not firing. The nerve actually is not firing. Okay, but the vestibular nuclei gets some responses from the outside from the cerebellum, from the compensatory mechanism. Okay, now what happens? Slowly the clamping is reducing. Why? The abnormal side is getting little bit of stimulation, and your clamping is getting reduced now. The next stage. What happened? Again, the nystagmus will continue. The same thing. Okay, the difference was maintained here. The no response got something, and your response side got your normal responses back. In the next stage, what happened? The clamping was completely removed. Okay, and this responses from the cerebellum is normal now, just like the previous ones. Before it was damaged, it was used to get this much of responses to the vestibular nuclei. Now it has got the same responses in the uh, affected side. But actually, the semicircular canal is not firing anything. It is only the understanding of the vestibular nuclei. There is no input from the right labyrinth. Okay, you can see here there is no input, but the vestibular nuclei understands it as, meaning guessing it as, responses. Okay, now the difference between this and this is absent. We have no nystagmus in the static, no movement. Okay, when there is a movement, this is static. Okay, when there is a movement, then it will check here. The fibers will increase, so you will have extended firing based on this. Okay, and then there is a movement on the right side, the left side it will have inhibition. So when this will reduce, this will maintain the same. So you have a difference here. Okay, is it clear or is it confusing? Okay, should I repeat? Okay, I will repeat. See, what happens is, we'll go from the first. This is normal vestibular apparatus. Okay, as we told previously, when I'm turning towards the right side semicircular canal will send more number of fires. When compared to the left one, it will reduce from the spontaneous rate. So you have the spontaneous rate, okay, and when there is a movement, it will be above or below it, which means above 100 or below 100. Okay, imagine if there is a vestibular lesion, which means the right side is not sending any more signal. Okay, which means completely gone, no, zero. But the right side, the left side is sending spontaneous rate normally. But when you compare this to no signal and some spontaneous, it looks like there is a movement. Okay, it looks like there is a movement. This is just like, looking richer. When someone goes in a Lamborghini car and you own a Maruti 800, okay, you look poor, right? You look poor. But when you compare you to a person who owns a cycle, you are far richer, right? Likewise, here you actually are comparing these two. One is your Lamborghini car, other one is your Maruti 800. Then this looks richer. It's excitatory. Okay. Here we have nothing, cycle, and you have your Maruti 800. Now you look richer. You look like getting stimulated, right? Excitatory. So the brain, the vestibular nuclei understands that the head is moving towards the left side. When it is moving towards the left side, the VOR comes into picture. What it does, it will try to move the eye towards the opposite direction, which is right side, which is slow phase. Okay, it goes slowly up. Okay, done. But actually, did the head movement take place? No. It was just the understanding of the vestibular nuclei. What does the saccade do next? It will try to bring back the picture into midline. So it's a fast response. It suddenly brings back the responses in the center. Okay, did it end? No, because spontaneous rate, it will keep firing, right? The spontaneous rate means it will keep firing when there is no response, when there is no movement at all. So again, when it continues to fire, then the vestibular nuclei thinks, okay, again the head has head has turned. So the process takes place. So vestibular, the nystagmus will continue forever, right? Till this part is clear. Okay. Then what happens? We don't want this nystagmus to continue. There is always adaptation happening in the whole of the body. Okay. If, for example, one example of adaptation is in a hearing impaired individuals, we have a specific area for the audition and for the vision. Since the visually the hearing impaired individuals don't use their auditory part of the brain much, and they all lip read, so their vision is important now. So what it does, the the areas will start borrowing the auditory areas. So visual area has become big. Okay, this is adaptation, right? So it changes according to the people. Likewise, the adaptation takes place in the next step. What it does, it brings back clamping. Clamping means clamp. You have your clamp, right? Which means trying to stop your nerve fibers firing. So it is trying to clamp it. When you have clamped it, the responses, the spontaneous responses that reaches the vestibular nuclei has reduced, which means below the spontaneous rate. Okay. Now compare this person, which means now you consider this as bike. This guy has a cycle. Okay. But still both are not equal. One looks richer, right? One is looking richer, but not that much of a difference. Like anytime, no, the difference when you check, it is not too much of a movement. It's considered. Okay. So what happens now? The vestibular nuclei thinks, compares these two responses and thinks that the head rotation is only little bit. So when the head is turning little bit, the eye will also move little bit on the opposite direction. So your responses here, nystagmus is reduced. Okay, previously it was very fast, now it is very slow. The amplitude is reduced, right? Okay, what happens in the next thing? As I told you, there is a connection between the cerebellum and the efferent, pathway between the cerebellum and the vestibular nuclei. That will help in bringing back few nerve firings. Like it is like an illusion. It's an illusion that's being created here. So it will get responses from the cerebellum that there is a response coming from the right labyrinth. In reality, there is no response coming from the semicircular canal, but the vestibular nuclei will receive inputs like that. Okay. Since it has started getting responses from the cerebellum, now the vestibular nuclei has started getting inputs. Okay. The clamping will cease. The clamping will reduce. Okay. So now it will go back to the spontaneous rate only. Okay. Now when you compare this to the cycle and the bike, here you are comparing the bike and the Maruti 800. Okay. Again, the difference is the same. Okay, the difference is the same. So then what happens? The nystagmus will continue because still there is a mismatch. It is not equal since there is a mismatch. Then what happens? The neural activity starts to increase and it comes back to a firing rate of spontaneous rate. So the cerebellum will help the vestibular nuclei to perceive the spontaneous activity, although the semicircular canal or utricle are not sending anything. Okay. Now when you compare this both, it looks like same. Okay, Maruti 800 and Maruti 800, which means both are equally rich. So there is no difference. So there is no movement of there is no vestibular ocular reflex happening. So there is no nystagmus happening. Okay, is it clear? Fine. So then what happens? There is one more short thing. Yeah. This is called as recovery nystagmus. Okay. Let's go back to the previous one. Here, the clamping happened, right? Okay. Why does the clamping happen? The clamping happened because it reduced the uh, spontaneous rate. Okay. The clamping means reduction of the spontaneous rate. Okay. Now the clamping has happened. But imagine there is a fluctuating problem. Okay. Meaning there, when there was a unilateral problem, then the brain started implementing clamping. After clamping is implemented, now the labyrinth became normal, fluctuating, like how you have in the Meniere's disease, fluctuating hearing loss. Likewise, you have fluctuating problem. So now the spontaneous rate is back to normal for the affected side. Now, when you compare, it looks like that the head is turning towards the right side, because when you compare, the right vestibular nuclei has more firing compared to the left ones, the normal ones. So what happens? The eye will beat towards the opposite side now. The eye will move towards the left side. Here you can see. So the eye is moving towards the left side. Okay. See, the this coming down doesn't mean the reduction. It means coming towards the left side. Okay. So this is your degree. This is your 0 degree. Turning of the eye downward means towards left side, and going up will mean towards the right side. Okay. Remember, you're looking at this point. You're standing here and you're looking at this point. Okay. You're standing here and you're looking at this point. When you look towards the right side, it will go up. When you look towards the left side, it will come down. Okay. See here. Okay. So you will have problem on the, you will feel like the good side is affected. Okay, this is recovery nystagmus. This is called as recovery nystagmus. Okay, is this confusing or it is okay? Should I repeat? Totally confusing. Okay, see, what happens here is we saw. Okay, what happened here? One side of the labyrinth is gone. Okay, so what has to be done? You have to implement clamping. Okay, we have implemented clamping. Till now it is clear. This is the usual way of treating if of handling the unilateral loss by the brain. Okay, this is what it does. Okay, it implements clamping. Let's imagine that clamping is done at this point, but it was a fluctuating loss, which means the labyrinth affected for some time and then it is back to normal now. Okay, it's back to normal, which means you can say that um, there was a blood block. Okay, there was a block because of which the right labyrinth was not working, and suddenly the labyrinth was released from the block. Now the blood supply is normal. The right labyrinth started functioning. So right labyrinth is normal now. But when you compare, okay, when you compare, the spontaneous rate of the right side is more when compared to the clamped spontaneous rate. Clamping means reduction of the spontaneous rate from the normal side. Okay, so when you compare this and you compare this, it looks like this is excitatory and this is inhibitory, right? So what does it mean? The head is moving towards the right side. Is it clear? When you have one vestibular nucleus getting more responses than the other, it means the head is turning. Okay, fine. After that, what will the vestibulo-ocular reflex do? Now the signal reaches the vestibular nuclei that the head is moving towards the right side. So the vestibular nuclei will send signal to the ocular nuclei, oculomotor nuclei, to ask the extraocular muscles to turn the eye towards the opposite side, which is left side. Okay, when it moves to the left side, the head is not move, but what the saccade will do, it will try to bring it back to the midline. That's why you're getting a fast face back to the right side towards the midline. Okay, is it clear? Okay, now there is a recent trend. This is one the recent trend I just found out. What it says is, depending if there is a vascular problem, if there is a vascular problem, and because of which the vestibular system is not working properly, there is a vertigo. And is there any way to pinpoint which part of the uh, semicircular canal or the utricle is damaged? They say with the help of knowing the blood supply, we can exactly say what is the problem. Okay, so how do we do that? We have this basilar artery which is sending to the anterior inferior cerebellar artery. From there you are getting labyrinthine artery. From there you have two divisions, common cochlear and the anterior vestibular. From common cochlear you are getting main and posterior vestibular. Okay, now what does this is how the blood supply is divided, the branches. Okay, now what does it supply? The main cochlear artery supplies the cochlea. Done. The posterior vestibular artery supplies posterior semicircular canal and saccule. Okay. The anterior vestibular artery supplies anterior semicircular canal, lateral semicircular canal, and utricle. Okay. Now, what they are trying to say is, if, for example, there is a lesion and this part, all the semicircular canal and the utricle will be functioning normal except cochlea. Okay, when you're testing a cochlea, all the things will be working normal except the cochlea because the damage is in the main cochlear artery. Okay, if there is a damage in the common cochlear artery itself, okay, what happens? Your anterior semicircular canal, lateral semicircular canal, and utricle will be functioning normally, and the responses from the test which which is done to test your saccule, your CVEMP, and your posterior semicircular canals, and we don't really have a direct test for it, and then the hearing test. All these three things will be affected, but these three things will be normal. Okay, if there is a problem in the labyrinthine artery itself, all the results of this test involving these structures will be affected. That's what they are telling.